Hello, everyone. We've now been progressing through advancing complexity of RAVR. One situation that's becoming more common is a situation where patients' native annulus may be too small for conventional prostheses. As we look at the lifetime management of patients, we sometimes need to focus on putting the largest prosthesis possible. So join us on this next episode on how to perform robotic aortic valve replacement and concomitant root enlargement.
In our pursuit to never place a valve prosthesis that is mismatched to the patient's body surface area, on occasion we do have to perform aortic root enlargements. Diamond patch enlargements, which essentially augment the non-coronary sinus, can be readily utilized to increase the valve prosthesis size by at least one size, occasionally two sizes. This is a patient that has a 23 millimeter valve that was really sized to a 21, but the patient's body habitus was enlarged, and we wanted to get in a 23 valve. And this essentially undermines the non-coronary sinus just above the annulus. Again, this is not an annular enlargement per se, it's a root enlargement. And so multiple size augmentation with annular enlargements is not what this is. This is really a root enlargement. And a fairly straightforward one to do is a autologous pericardial patch. You can see it's anchored using a double inverted stitch technique at the base. And then once we've encroached the non-coronary sinus, we'll involute this with a slight running accordion-like stitch to come across to the other side and bring the two edges of the aortotomy together. I prefer to use a pledget in this case, in these robotic cases, just for added security. And then a contralateral pledget. Once that's done, then we would run the rest of the rest of the aorta, rather, as we've already shown before, to complete the aortotomy closure. And then commencing medially in a similar manner we have done in previous videos. With a horizontal mattress as the first layer, and then a running suture as the second layer. And this completes the aortotomy closure. And then we test with antegrade cardioplegia or cold blood to make sure we have excellent hemostasis. Now here's another example. And in this case, this is a mechanical prosthesis, and we have placed in a mechanical valve in a smaller patient. And also placed a 23 millimeter valve for long-term durability. So this is the inverting stitch going through the Dacron patch and then securing it through the pledget. So this is a double suture, essentially. And then that brings that on the inside of the aorta. And then this is run on both sides. In a simple running fashion. This is not a horizontal mattress, given the use of the patch. You see the coronary ostial catheters there just to give some cold blood while we're proceeding for superlative myocardial protection. And here we are at this juncture, we now have essentially replaced the non-coronary sinus. And since this was all that was needed in this case, decided to make this a diamond patch. Really increasing it by one size in terms of the prosthetic replacement. And so now we'll proceed to finish this just like we had done for the previous case. Largely at the midpoint. And then an interlocking accordion-like bite to then come across to the other side. Over a pledget to create that diamond-like closure. Then we'll close the other aspect of the aortotomy immediately. And this one will be a horizontal mattress to make it over back to the other side. Followed by a running suture to conclude the root enlargement. Following which we will do antegrade testing, showing competence. Now, I wanted to illustrate this Dacron gusset patch enlargement. This is a situation where we want to enlarge by at least one size, but more likely two sizes. This is a patient who's sized to a 19 annulus and receives a 23 millimeter valve. Again, not a root enlargement, not an annular enlargement per se, but a root enlargement. Getting the suture down in the base, both limbs of the suture up, and then both limbs back through the intima and then through the anchoring pledget. Then followed by the other stitch, then delivering the Dacron patch for its anchoring. Then we'll proceed to meticulously expand this, and this is a running 4-0 polypropylene suture with the patch on the inside for maximum hemostasis with aortic expansion. But what's different in this particular case is we call this a gusset patch enlargement because we've created this gusset-like linear expansion. So it's not only the aortic root per se, but it's the actual whole ascending aorta in order to fully expand for the size, but also to avoid any coronary embarrassment that might occur with a smaller patch. Sometimes these prostheses do have a slight encroachment and proximity to the left main, so we do want to really make sure we have excellent hemodynamics and blood flow down the coronary. And when our goal is to always put the largest prostheses possible, this is the method we tend to favor. And this is continuing this enlargement across to the entire aortotomy and coming up from the other side. As you can start to see, we've augmented the entire ascending aorta along with it. This gusset patch technique has become our routine approach as it provides the maximum enlargement without crossing the annulus and allows us to always perform the largest possible valve we can to avoid patient prosthesis mismatch with a focus on excellent, durable, long-term results.
So now we just saw how to perform aortic root enlargement at the time of RAVR. If we reflect back now on this series, we've gone through the fundamental setup, tableside choreography, and the performance of straightforward and increasing complexity of RAVR, ending with RAVR with aortic root enlargement. Now join us in the next season where we're going to take this step even further. and talk about much more complex cases, the performance of multiple concomitant procedures, and advancing pathologies.